Hello everyone. So we will be starting with chapter 13 of illustrated textbooks for pediatrics, that is nutrition. Features of nutrition in children are they are particularly vulnerable to suffer from poor nutrition, whether inadequate in quantity or in quality or quantity for short or long periods because of their additional requirements for growth and development. Early nutrition affects the risk of developing a range of adult diseases. There are many reasons why breastfeeding is the optimal form of feeding for newborn infants. It is now possible to provide nutritional support to children unable to eat normal food with specialized feeds, enteral tube feeding, or by parenteral nutrition. Malnutrition contributes to over one third of global deaths of children under 5 years of age, with about 800 million, i.e., 1 in 9 people in the world not having enough food to lead an active and healthy life. Vitamin D deficiency problematic in the UK. Over one third of 11 to 15-year olds in the UK are overweight or obese. The nutritional vulnerability of infants and children. Infants and children are more likely to suffer adverse consequences from poor nutrition than are adults. There are a number of reasons for this. Low nutritional stores, newborn infants, particularly those born prematurely or who have experienced poor fetal growth, intrauterine growth restriction, have poor stores of fat and protein. The smaller the child, the less the calorie reserve, and shorter the period the child will be able to withstand starvation. High nutrition demand for growth. Rapid growth during infancy means that nutritional requirements are high during this period. The proportion of dietary energy intake used for growth is 35% in the first 3 months, 5% at 1 year of age, and 2% by 3 years of age, and 1% to 2% until mid adolescence. The risk of growth failure from restricted energy intake is therefore greater in the first 6 months of life than in later childhood. Even small but recurrent nutritional deficits in early childhood will lead to cumulative deficit in weight and height. Now, these are rapid brain growth and development. The brain grows rapidly during the last trimester of pregnancy and throughout the first 2 years of life. The complexity of interneuronal connections also increases substantially during this time. This process appears to be sensitive to undernutrition and is particularly important in the premature newborn. Even modest energy deprivation during periods of rapid brain growth and differentiation leads to an increased risk of adverse neurodevelopmental outcome. This is not surprising when one considers that at birth the brain accounts for approximately two-thirds of basal metabolic rate and at 1 year of age for about 50%. Many studies have drawn attention to the delayed development seen in children suffering from protein energy malnutrition due to inadequate food intake, although adverse psychosocial factors in food, poor environment are likely to contribute. Effects of acute illness or surgery. During acute illness or surgery, children may not be able to eat. Recurrent infections are common in infancy and reduce food intake while increasing nutrition demands. Following surgery after a brief anabolic phase, catecholamines secretion is increased, causing the metabolic rate and energy requirement to increase. Urinary nitrogen losses may become so great that it is impossible to achieve a positive nitrogen balance and weight is lost. After uncomplicated surgery, this phase may last for a week, but it can be much longer after extensive burns, complicated surgery, or severe sepsis. Thereafter, previously lost tissue is replaced and a positive energy and nitrogen balance can be achieved. However, infants may not show catch-up growth unless their energy intake is as high as 1500 to 200 kilocalorie per kilogram per day. Normal requirements are 95 to 115 kilocal per kg per day. In small infants with very marked growth faltering, for example, post-surgery, it can be impossible for them to tolerate the feed volumes needing for catch-up growth, and a period of partial parental nutrition may be necessary to achieve growth recovery and reestablish full enteral feeding. Long-term outcome of early nutritional deficiency, linear growth of populations. Growth and nutrition are closely related such that mean height of a population reflects its nutritional status. As living conditions have improved in high-income countries, people have become taller. In the Netherlands, for example, average male height has increased by 20 centimeters over the last 150 years. Natural selection may also be a factor for this instance. The taller Dutch adults have been found to have greater number of children. Height is adversely affected by lower socioeconomic status with increasing number of children in a family. Disease in adult life. There is considerably epidemiological evidence suggesting that early nutrition and lifestyle have long-term effect on later health and risk of illness. Developmental programming include coronary heart disease, stroke, non-insulin dependent diabetes, and hypertension. Currently, 3 hypotheses are proposed: the fuel-mediated in utero hypothesis, and accelerated postnatal weight gain hypothesis, and the mismatch hypothesis. These are not mutually exclusive, we could have a greater or lesser impact in different circumstances. This is the death rate from coronary heart disease, according to birth weight, showing increased rate in low birth weight babies. This is the graph which shows the relative contribution of basal metabolic rate derived from brain, liver, and muscle changes with growth. Brain accounts for 2/3 of basal metabolic rate at birth, but this falls 25% in adults. Now, the reference value for energy and protein requirement 0 to 6 months is 115 kilocal per kg per 24 hours. Protein gram per kg is 2.2. 6 to 12 months is 95 kilocal, and protein is 2.0. 1 to 3, 95, and protein is 1.8 gram. 4 to 6 years is 90 kilocal, and protein is 1.5. 7 to 10 years 75, and protein is 1.2. Adolescent male and female 11 to 14 years 65, 55, and 1 gram per kg, and in 15 to 18 years 60 to 40 kilocal per kg, and it is 0.8 gram per kg. Summary: nutrition vulnerability. Infants are more vulnerable to poor nutrition because of poor stores of fat and protein. Extra nutrition demands for growth. The weight of a term infant doubles by 4 months and triples by 1 year of age. Periods of reduced food intake and increased nutrition demand during illnesses or surgery. Now, infant feeding. Breast milk is the natural food for infants. The popularity of breastfeeding and who should perform this task has reflected fashion and social class in Europe until the middle of the 17th century. The aristocracy would generally favor a wet nurse. The development of infant formulas resulted in a marked decline in the popularity of breastfeeding, but breastfeeding is now universally advocated. Exclusive breastfeeding for the first 6 months is the current WHO recommendation, which has been endorsed by the Department of Health in the UK. Shorter periods of breastfeeding also advantageous. In 2012, in the UK, 81% of babies are breastfed at birth, which is steadily rising. A higher proportion of mothers from a managerial and professional backgrounds start breastfeeding compared with mothers from routine and manual occupation, although this gap is closing. This is the current hypothesis on early metabolic programming of adiposity and related diseases. Full mediated in utero hypothesis, fetal overnutrition, maternal obesity, gestational diabetes, large weight gain in pregnancy, mismatch hypothesis, fetal undernutrition, IUDR, and postnatal overnutrition. Accelerated postnatal growth hypothesis, showing postnatal overnutrition, overfeeding, excessive protein intake, visceral adiposity, diabetes mellitus, insulin resistance, metabolic syndrome, coronary heart disease, and stroke, also influenced by genes, lifestyle, and environment. This is the prevalence of breastfeeding. Exclusive breastfeeding, no formula milk in proportion of infants giving solid feeds during the first 9 months of life in the UK. Over the last 10 years, there has been a marked increase in the prevalence of breastfeeding, delay in weaning onto solid food. Advantages: In low-income countries, breastfeeding dramatically improves survival during infancy, mainly by reducing gastrointestinal infections. It is estimated that 1.3 million to 1.45 million deaths could be prevented in 42 low-income countries by increased level of breastfeeding. It is therefore one of the WHO's four main strategies to reduce child mortality. In developed countries, there is no convincing evidence of reduced mortality associated with breastfeeding, but GIT, lower respiratory tract infections, otitis media is reduced. Breast milk also has a protective effect against necrotizing enterocolitis in premature infants. Breastfeeding is associated with a reduced incidence of obesity, diabetes mellitus, and hypertension later in life. The benefits of breastfeeding are difficult to demonstrate, as studies comparing breast milk and formula feeds cannot generally be randomized and are almost always observational with potential confounders such as social class, education, smoking. Many mothers who breastfeed find that it helps them establish an intimate, loving relationship with their baby. Morning breastfeeding is not always straightforward, and help and encouragement are often required. Health advantages to the mother include a reduced risk of type 2 diabetes and breast and ovarian cancers. Breastfeeding may also be of economic benefit to the country from reduced infections in infants and lifetime breast cancer risk for mothers. Exclusive breastfeeding in early infancy is life-saving in developing countries. Potential complications. It is difficult if a baby is getting enough milk except by demonstrating normal weight gain through regular weight checks every few days in a couple of weeks, then weekly until feeding is well established. Successful breastfeeding in twins can be achieved, but it is really possible to totally breastfeed triplets and high order birds. Preterm infants can be breastfed, but the mother will need to learn how to express milk from the breast until the infant can suck. Obtaining sufficient milk can be a problem. Donor breast milk has made a return of neonatal units as collected from the non-feeding breast during suckling by mothers of well babies in the community and donated to a milk bank. Breastfeeding is restricted for the mother, as others cannot take charge of a baby for any length of time. This is particularly important if she goes to work and may delay her return, which may cause financial hardship for the family. Facilities for breastfeeding in public places remains limited. Failure to establish breastfeeding will sometimes cause significant emotional upset in the mother. Plotting growth on a centile growth chart helps identify inadequate nutrition or other problems. Establishing breastfeeding, colostrum rather than milk is produced for the first few days. Colostrum differs from mature milk in that the content of protein immunoglobulin is much higher, volume are low, but water or formula supplements are not required while the supply of breast milk is becoming established. The first breastfeed should take place as soon as possible after birth. Subsequently, frequent suckling is beneficial as it enhances the secretion of the hormones initiating and promoting lactation. Primates appear not to breastfeed instinctively. Monkey bred in captivity have to be taught how to care for their young and do not learn the skill when denied the normal social opportunity in the wild to observe child rearing. It is therefore important that breastfeeding should have as high a public profile as possible. Women who have never seen an infant being breastfed are less likely to want to breastfeed themselves. Education in schools and during pregnancy about the advantages in breastfeeding is likely to have a positive effect. Advice and support from other women who have breastfed may be important with early problems such as engorgement or cracked nipples. WHO recommends continuing breastfeeding until 2 years of age. The American Pediatrics Association until 1 year of age. Newborn infants or mothers planning to breastfeed should ideally not be given any formula feeds. Why breast is best? Advantages of breast milk. Advantages of breastfeeding for the infants are that it provides iodine nutrition for infants during the first 4 months to 6 months of life. It's life-saving in developed countries, reduces risk of GIT, respiratory infection, otitis media, and necrotizing enterocolitis enhances the mother-child relationship, reduces the risk of insulin-dependent diabetes, hypertension, and obesity in later life. Advantages for the mother are that it promotes close attachment between mother and baby, increases the time interval between children, which is important in reducing birth rate in developing countries, reduces risk of breast and ovarian cancer and type 2 diabetes. Scientific explanation of some of the properties of breast milk: anti-infective properties, humoral, secretory. IgA comprises 90% of immunoglobulin in human milk, provides mucosal protection, but of uncertain benefit. Bifidus factor promotes growth of lactobacillus bifidus, which metabolizes lactose to lactic and acetic acid, resulting low pH may inhibit growth of GIT. Pathogens: lysozyme, bacteriolytic enzyme, lactoferrin, iron binding protein inhibits growth of E. coli. Interferon, antiviral agent, cellular macrophages, phagocytic, synthesizes lysozyme, lactoferrin C3, C4, lymphocytes. T cells may transfer delayed hypersensitivity responses to infants. B cells synthesize IgA. Nutrition properties: protein quality, more easily digested curd, whey to casein ratio 60:40. Lipid quality: rich in oleic acid, improved digestibility and fat absorption, fat metabolism, enhanced lipolysis from breast milk lipase, calcium to phosphorus ratio of 2:1, reduces hypocalcemic tetany and promotes calcium absorption. Renal solute load: low, iron content bioavailable, 40 to 50% absorption, long chain polyunsaturated fatty acids, structural lipids important in retinal development. Formula feeding: infants who are not breastfed require a formula feed. Most are based on cow's milk, but unmodified cow's milk is unsuitable feeding in infancy as it contains too much protein and electrolytes and inadequate iron and vitamins. Even after considering modification, differences remain between formula feeds and breast milk. All infant formula feeds currently available in the UK have been modified to make their mineral content and renal solute load comparable with that of mature human milk. Since these changes were introduced in the UK in the 1970s, there has been a marked reduction in the incidence of hypernatremic dehydration in infants with gastroenteritis. Over time, additional modifications have been made to formula feeds, including the addition of polyunsaturated fatty acid, nucleotides, prebiotics, and probiotics. Whether or not these provide additional clinical benefits is often uncertain, and it seems unlikely that an artificial feed will ever mimic the complexity of breast milk. There is no evidence that any of the many brands of formula milk is superior to any other. 1981, the WHO introduced a code of marketing of breast milk substitutes. This came out of concern that aggressive marketing of formula was associated with an increase in mortality, malnutrition, and diarrhea in young infants in developing countries. The code prohibits any advertising of infant formula bottles and deeds and gifts to mothers or inducement to health workers. Potential complications of breastfeeding: unknown intake, volume of milk intake not known, monitor weight gain, transmission of infection, maternal CMV, Hep B and HIV, risk of transmission of the baby. Breast milk jaundice, mild self-limiting unconjugated hyperbilirubinemia continuing breastfeeding. Transmission of drugs, antimetabolites, and some other drugs contraindicated. Check formulary. Nutrition inadequacies: breastfeeding beyond 6 months without timely introduction of appropriate solids may lead to poor weight gain and rickets. Vitamin K deficiency: insufficient vitamin K in breast milk to prevent hemorrhagic disease of newborn. Supplementation is required. Potential transmission of environmental contaminants, nicotine, alcohol, caffeine, etc. Less flexible: other family members cannot help but take part. More difficult in public places. Emotional upset or difficulties or lack of success can be upsetting. Physiological breastfeeding: baby uses rooting, sucking, and swallowing reflex to locate nipple and feed. Tactile receptors in nipple activated hypothalamus sends efferent impulses to anterior and posterior pituitary. Anterior pituitary prolactin secretion stimulates the secretion by cuboidal cells in the acene of breast. Posterior pituitary oxytocin secretion results in contraction of myoepithelial cells in the alveoli, forcing milk into larger ducts, the so-called let-down reflex. The physiology of breastfeeding, introduction of whole pasteurized cow's milk. Breastfeeding formula feeding is recommended until the age of 12 months, and there are advantages in continuing to 18 months of age. Pasteurized cow's milk given before 12 months of age is associated with increased risk of iron deficiency, but may be given from one if it is deficient in vitamin A and C and D and iron, and supplementation required unless infants are having good diet of mixed solids. Alternatively, a follow-on formula can be used. These contain more proteins and sodium than infant formula, and in contrast to cow's milk, are fortified with iron and vitamins. Children on cow's milk should receive full-fat milk up to age of 5 years. Children on cow milk should receive infants should not be given unmodified cow's milk in the first year of life. Specialized infant formula. A specialized formula may be used for the preterm infants. High energy and mineral content in infants with cow's milk, protein allergy, lactose intolerance, primary lactase deficiency, on post-gastroenteritis intolerance, cystic fibrosis, neonatal cholestatic liver disease, and following neonatal intestinal resection. In a cow's milk-based formula, the protein is derived from cow's milk protein. The carbohydrate is lactose, and the fat is mainly long-chain triglycerides. In a specialized formula, the protein is derived from hydrolyzed cow's milk protein, amino acids are from soya. Carbohydrate is glucose polymer, and the fat is a combination of medium and long-chain triglyceride. Medium-chain triglyceride directly absorbed in the small intestine need neither pancreatic enzyme nor bile salts for this process. Soya formula should not be used for infants under 6 months of age, as it is high aluminum content and contains phytoestrogens, plant substances that mimic the effect of endogenous estrogens. There is no compelling evidence the use of specialized formula prevents development of allergic or autoimmune diseases, asthma, eczema, cause no protein allergy. Formula containing rice starch that become more viscous in the stomach will fall in pH, can be used for uncomplicated gastroesophageal reflux. These are known as anti-reflux milks. Details of different formula feeds can be found in the British National Formula for Children. This is the comparison of human milk, cow's milk, recommended content of infant formula milk per 100 kilocal. Energy kilocalorie is 66, cow's milk is 65, and formula is 60 to 70 per 100 ml. Protein is 1, cow's milk is 3.4, and infant formula is 1.8 to 3. Carbs are 7, cow's milk is 4.6, and infant formula is 9 to 14. Casein weight 40 in ratio 60, 80 ratio 20, and 40 to 60 to 80 to 20. Fat is 3.8, cow's milk is 3.7, and infant formula is 4.4 to 6. Sodium is 0.65, cow's milk is 1.9, and infant formula is 0.87 to 2.6. Calcium is 0.85, cow's milk is 3, and infant formula is 1.25 to 3.5. Phosphorus millimole 0.48, cow's milk is 3, and infant formula is 0.8 to 2.9. Iron is 1.2, 0.36 in cow's milk, and 5.4 to 23 is infant formula. Now, weaning. After 6 months of age, breast milk becomes increasingly nutritionally inadequate as a sole feed as it doesn't provide sufficient energy, vitamins, or iron. Solid foods are recommended to be introduced from around 6 months of age, not before for 17 weeks or no later than 26 weeks. This is done gradually, initially with small quantities of pureed food. Root vegetables or rice, food high in salt and sugar should be avoided, and honey should not be given until 1 year of age because of risk of infantile botulism. Currently, there is no strong evidence that delayed introduction of more energenic food delays or prevents development of food allergy prevents development of food allergy. On the contrary, research has shown that early introduction of peanuts in infancy significantly reduces risk of peanut allergy in childhood. Weight faltering. Weight faltering is suboptimal weight gain in infants and young children. If prolonged and severe, it will result in reduction in height and length, stunting, and reduction in head growth, and may be associated with delayed development. This was often described as failure to thrive, but the term has fallen out of favor in the UK as it is regarded as somewhat pejorative is still used in other countries. There is no concrete definition and identification is often problematic. Growth is determined by plotting serial measurements of weight, length, or height, and head circumference using WHO growth charts for boys and girls. Healthy general weight will fluctuate, but it will usually progress within one centile space. Within one centile space, the distance between two major centile lines on the growth chart. However, size of birth is determined not only by genes but also by the intrauterine environment. Over the first few weeks, infants who are larger at birth will often cross down centiles, catch down growth, whereas small babies will move up centiles, catch up growth. To find their genetic centile growth lines, infants who become acutely ill will often lose weight but will regain their weight centile within 2 weeks to 3 weeks. Identifying weight faltering. Weight faltering describes a sustained drop down two centile spaces. After the first 4 months, only around 0.5% children in the UK will do this. A single observation of weight is difficult to interpret unless markedly discrepant from the head circumference or length. All babies should be weighed during the first week to assess feeding, and then at around 8, 12, 16 weeks and at 1 year, and whenever concerns are raised. In addition, the further the weight is below the second centile, the more likely child is weight faltering. Any child whose weight crosses two centile lines or is below the 0.4 centile or has a body mass index less than the second centile should be evaluated. Infant with growth faltering needs to be differentiated from a normal but small or thin baby. If the child was born preterm, this should be allowed for reporting growth during the first 1 to 2 years of age, depending on the degree of prematurity. Some infants with severe intrauterine growth restriction remain small, though most exhibits catch-up growth. Causes of weight faltering. The causes of faltering growth are listed in the picture. In most, the cause is inadequate intake of food, but the reason for this is often multifactorial. Traditionally, the causes have been divided into organic and non-organic causes. However, organic causes are only found in 5% to 10%, and there are almost always symptoms and signs pointing to the underlying disease. Although weight faltering is often considered to be a manifestation of poverty and is certainly true in poor societies. Poorer societies in the UK have not found an association with low social economic status or poor educational attainment. While neglect and child abuse must always be considered, it is relatively unusual, true in perhaps only 5% of cases. Evidence for the role of maternal depression is conflicting, with some studies of suggesting an association and others being unable to demonstrate a link. Conversely, in children without symptoms and signs of disease, investigation are likely to be negative. Clinical features investigation. Weight faltering is confirmed and dietary history should be taken to include history of milk feeding, age at weaning, range and type of foods now taken, mealtime routine, and eating and feeding behaviors. A 3-day food diary will provide a more detailed, accurate picture of intake. If possible, observe a meal being taken. Consider also, was the child born preterm or had intrauterine growth restriction? Is the child well with lots of energy, or does the child have other symptoms such as diarrhea, vomiting, cough, or lethargy? The growth of other female family members and any illnesses of the family. Is the child development normal? Are there psychosocial problems at home? This shows the cause of growth faltering, inadequate intake, environmental, inadequate availability of food, feeding problems, insufficient breast milk or poor technique, incorrect preparation of formula, insufficient of unsuitable food offered, lack of regular feeding times, infant difficult to feed, resist feeding or disinterested, conflict, overfeeding, intolerance of normal feeding behavior, messiness, throwing food around, leading to an early cessation of meals, problem with budgeting, shopping, cooking food, famine, low social honesty, psychosocial deprivation, poor mental infant attraction, maternal depression, poor maternal education, neglect to child abuse, including factitious illness, deliberate underfeeding to generate weight faltering. Underlying pathology, impaired sex swallow, oromotor dysfunction, neurological disorder, for example, cerebral palsy, cleft palate, chronic illness leading to anorexia, Crohn's disease, chronic kidney disease, cystic fibrosis, liver disease, etc. Inadequate retention, vomiting, severe gastroesophageal reflux, malabsorption, celiac disease, cystic fibrosis, cow protein allergy, cholestatic liver disease, short gut syndrome, post-necrotizing enterocolitis, neck, failure to utilize nutrients, syndromes, chromosomal disorders, for example, Down syndrome, intrauterine growth restriction, or extreme prematurity, congenital infections, metabolic disorders, for example, congenital hypothyroidism, storage disorders, amino organic acid disorders, increased requirements, cytotoxicosis, cystic fibrosis, malignancy, chronic infection, HIV, immune deficiency, congenital heart disease, chronic kidney disease. If organic disease is the cause, suggestive symptoms and signs are usually present. Examination should focus on identifying signs of organic disease such as dysmorphic features, signs suggestive of malabsorption, distended abdomen, thin buttocks, misery, signs suggestive of chronic respiratory disease, signs of heart failure, and evidence of nutrition deficiency, cholonicia, angular stomatitis in some children with growth faltering. A full blood count and serum ferritin may be helpful to identify iron deficiency anemia. This is usually secondary to inadequate iron intake, and correcting it may improve appetite. Most instances, no investigation are required. Further information about the child and family from the health visitor, general practitioner, or other professionals involved with the family can be particularly helpful. Investigation to be considered are listed in the box. Management. The management of most weight faltering is carried out in primary care using mealtime observations and food diaries. Health visitors can assess and support families to improve feeding and increase calorie intake. Access to specialist support may be required. A pediatrician dietitian is helpful in assessing the quantity and composition of food intake, recommending strategies for increasing energy intake, and a speech and language therapist has specialist skills with feeding. Disorders. Input from a clinical psychologist and from social services may also be needed. Nursery placement can be helpful in alleviating stress at home and assisting with feeding. The key outcome measures in a rise is a rise up the weight centile. This usually begins 4 to 8 weeks after intervention. In children under 6 months of age, severe weight faltering, hospital admission may occasionally be necessary for active refeeding and multidisciplinary team involvement. While being on a children's ward, we offer the opportunity to observe and improve the parents' method and skill in feeding. This lead transfers back to home. As children's ward are busy and focused on acute illness, admission is unlikely to be helpful unless there is a clear and agreed pre-admission plan. In extreme circumstances, hospital admission can be used to demonstrate that the child will gain weight when fed appropriately. Now, the case history of weight faltering. Jamie, age 11 months, was causing concern to his health visitor as he was not putting on any weight. She arranged for him to be assessed by his general practitioner, who found that he was otherwise well. His mother was a single parent who left school at 16 years of age and had Jamie at the age of 18. They lived in a high rise flat. Jamie's wife received income support. Her own mother lived on the other side of the city. On visiting the home, the health visitor found Jamie's mother to be tense and anxious. In particular, she was worried about making ends meet. She fed Jamie the same food as she ate herself, together with cow's milk, which she had started at 6 months of age. The meals were chaotic and there was no dining table. After a few mouthfuls, Jamie stopped eating. His mother did not coax him but became frustrated and angry. Jamie's health visitor suggested strategies for increasing Jamie's food intake. She continued to provide support and encouragement to his mother and arranged a nursery placement for Jamie. By 2 years of age, he had crossed one centile space upward but still ate erratically. The strategies for increasing energy intake: dietary 3 meals and two snacks each day, increase number and variety of foods offered, increase energy density of food, for example, add cheese, margarine, and cream, limit milk intake to 500 ml per day, avoid excessive intake of fruit juice and squash. Behavioral: offer meals at regular times with other family members, praise when food is eaten, ignore when not, limit mealtime to 30 minutes, eat at same time as child, avoid mealtime conflict, never force feed. Investigation to be considered: faltering weight in child with worrying signs or symptoms of disease. Investigation: full blood count and differential white cell count, anemia, neutropenia, lymphopenia, immune deficiency, serum creatinine, urea, electrolytes, acid-base status, calcium, phosphate, renal failure, renal tuberculosis, metabolic disorder, Williams syndrome, liver function test, liver disease, malabsorption, metabolic disorders, thyroid function test, hypothyroidism or hyperthyroid, acute phase reactant, CRP, inflammation, ferritin I deficiency, anemia, immunoglobulins, immune deficiency, IgA, TTG, IgA, tissue transglutaminase, antibodies, celiac disease, urine microscopy, culture in dipstick, urinary tract infection, Andrelian disease, stool microscopy, culture in elastase, intestinal infection, parasite elastase decreased in pancreatic insufficiency, karyotype in girls, Turner syndrome, sweat test, chest x-ray, cystic fibrosis, other respiratory disorders. Outcome: weight falling appears to have a long-term effect on growth, with children remaining on a low centile. However, a randomized controlled trial primary care intervention has shown that at 4 years of age, children who received intervention were heavier and taller than untreated controls. Weight faltering also appears to have an adverse effect on cognition. Although this is small, some children continue to undereat. As shown in the case history summary, weight falling is a description, not a diagnosis. Weight of infants are only helpful if measured accurately and plotted on a periodic central growth chart. Is present in if an infant's weight falls across two centile spaces, is more likely to be present the further the weight is below the second centile. Although complex in origin and multifactorial, the final common pathway is inadequate food intake. If there is underlying pathology, it is almost always accompanied by abnormal symptoms or signs. Most affected infants and toddlers do not require any investigation and are managed in primary care by dietary and behavioral modification designed to increase energy intake and monitoring growth. Malnutrition: worldwide malnutrition is responsible directly or indirectly for about a third of all deaths of children under 5 years of age. Malnutrition from inadequate food intake also continues to occur in developed countries, as a result of poverty, parental neglect, or poor education. Specific nutrition deficiency, particularly of iron, remain common in developed countries. Restrictive diets may be iatrogenic as a result of exclusion diets or parental food fads, or maybe self-inflicted. Moderate malnutrition also occurs in 20-40% children, especially children in hospital. At particular risk are those with long-term illness, for example, the preterm, congenital heart disease, malignant disease during chemotherapy or bone marrow transplantation, chronic gastrointestinal conditions such as shortcut syndrome following extensive bowel resection or inflammatory bowel disease, chronic kidney disease or cerebral palsy. Malnutrition results from a combination of anorexia, malabsorption, and increased energy requirements because of infection or inflammation. Malnutrition in older children and adolescents may also result from eating disorders. Assessment of nutritional status evaluation is divided into assessment of past and present dietary intake, anthropometry, and laboratory assessment, as shown in the figure. Dietary assessment: parents are asked to record the food the child eats during several days. This gives a more objective guide to food intake. This shows nutritional assessment: anthropometry, weight, height, mid upper arm circumference, and skin fold thickness. Laboratory is low plasma albumin, low concentration specific minerals and vitamins, food intake, dietary recall, dietary diary, immunodeficiency, low lymphocyte counts, impaired cell-mediated immunity. Anthropometry: weight and height are key measurements. Skin fold thickness of the tricep reflects subcutaneous fat stores and can be measured with calipers. While it is difficult to measure skin fold thickness accurately in young children, mid-upper arm circumference, which is related to skeletal muscle mass, can be measured easily and repeatedly and is independent of age in children aged 6 months to 5 years. It is especially useful for screening children for malnutrition in the community. Lab investigations: they can be used in detection of early physiological adaptation to malnutrition. Blood clinical history examination and thermometry are of greater value than any single biochemical or immunological measurements. Consequence of malnutrition: malnutrition is a multi-system disorder when severe immunity is impaired, wound healing is delayed, operative morbidity, mortality is increased. Malnutrition worsens the outcome for women. For example, respiratory muscle weakness may delay a child being weaned from mechanical ventilation. Malnourished children are less active and more apathetic. These behavioral abnormalities are rapidly reversed with proper feeding, but prolonged and profound malnutrition can cause permanent delay in intellectual development. The role of intensive nutritional support: children with long-term disorders who are malnourished will grow better if given supplemental nutritional support, which may be provided by the enteral and parental route. Enteral nutrition is used when the digestive tract functions and maintains gut function as safe. Feeds are given nasogastrically by gastrostomy or occasionally via feeding tube in the duodenum. For example, if there are problems with vomiting. Feeds are often given continuously overnight, allowing the child to feed normally. In the day, gastrostomies can either be created endoscopically or surgically. If this is the percutaneous gastrostomy, peg tube for enteral feeding in a child with severe neurodisability unable to feed by mouth. Unlike nasogastric tube, the peg tube is not usually visible to others and is much less likely to be accidentally displaced. Tubes can last for several years before needing to be replaced. This is the home parental nutrition for patients with intestinal failure is associated with good quality of life. This boy has remained well breastfed now 5 nights a week since he was a newborn infant. His parental nutrition is being set up whilst on a camping holiday. Long-term supplemental enteral nutrition is required more than 6 weeks. Gastrostomy is preferred as it avoids repeated replacement of nasogastric tube, which is distressing for the child. Now, the PN parental nutrition can be used exclusively or as an adjunct to enteral feeds to maintain or enhance nutrition. The aim is to provide a nutritionally complete feed in an appropriate volume of IV fluids. Energy is given as glucose together with a fat emulsion, usually derived from soybean oil, sometimes combined with fish oil, medium triglyceride, and olive oil, whereas nitrogen is supplied as synthetic amino acids in a combination resembling of egg protein. Electrolytes and a full range of vitamins, micronutrients, and trace elements also given. Clinical deficiencies such as zinc deficiency causing erythematous rash around the mouth and anus may occur and monitoring is required. Many patients are treated newborn with an immature GIT require PN for a few weeks until they're able to tolerate full atrial feeds. Some children depend on long-term PN, and if their condition is stable, can be managed at home with PN being given overnight so that they are not tied to an infusion pump in the day. Common reason for needing long-term or short bowel syndrome, major loss of bowel from complicated gastritis or a volvulus. Enteropathy is often with onset of severe diarrhea in very early life, or motility disorders such as long segment Hirschsprung disease. PN is a complex, expensive form of therapy requiring a multidisciplinary team incorporating the skills not only of medical and nursing staff but also pharmacists, dietitians, surgeons, and interventional radiologists. Short term, it is possible to deliver it via cannula in a peripheral vein. Long term, it is delivered via a central venous catheter, as this allows infusion of hyperosmolar resol solutions and reliable venous access. The CVC may be inserted surgically or under radiological guidance. Complications include CVC, sepsis or blockage, venous thrombosis, and intestinal failure associated liver disease. Severe malnutrition. Severe malnutrition continues to be a major problem in many low and middle income countries. WHO recommends that nutritional status express the weight for height, a measure of wasting, and an index of acute malnutrition. The weight is plotted against height on a WHO standard growth chart, and a number of standard deviations described as z-score below the median is determined. Mid, upper arm circumference, color coding of tape measures allow readily identifications of moderate and severe malnutrition. Height for age, a measure of stunting, and an index of chronic malnutrition. Severe protein calorie malnutrition is classified as marasmus, kwashiorkor, marasmic, kwashiorkor. In marasmus, the child has a wasted, wizened appearance. Anemia is not present. Affected children are often withdrawn and able. In kwashiorkor, there is general edema as well as muscle wasting. Because of edema, the weight may not be as severely reduced as in marasmus. In addition, there may be a flaky pain skin rash with hyperkeratosis and disformation, a distended abdomen, and large liver, usually due to fatty infiltrations, agular stomatitis, hair that is sparse and depigmented, diarrhea, hypothermia, bradycardia, and hypertension, low plasma albumin, potassium, glucose, and magnesium levels. It is unclear why some children with protein energy malnutrition develop kwashiorkor and others develop marasmus. There's some evidence that kwashiorkor is a manifestation of primary protein deficiency with energy intake relatively well maintained. It often occurs in communities where infants are not weaned from the breast until about 12 months of age, and subsequent diet is relatively high in starch. Kwashiorkor often develops after an acute intercurrent infection such as measles or gastroenteritis. In practice, it is sometimes difficult to clearly separate the two. When the term marasmic kwashiorkor is used, severe acute malnutrition is defined as a presence of any of the following: weight for height more than 3 standard deviations, more than -3 z-score below the median on the standard WHO growth chart, mid upper arm circumference less than 115 mm in children 6 months to 5 years old, bilateral edema. Both weight for height and mid-arm circumference are measured as they identify slightly different groups of children. Edema identifies severe kwashiorkor. Management: most children with severe acute malnutrition have an appetite and an alert and can be managed within the community with ready-to-use therapeutic food, which has revolutionized its treatment. It is based on peanut butter mixed with dry skim milk and vitamins and minerals, and is consumed rightly by the child. Children with no appetite, severe edema, or medical condition are less than 6 years of age, 6 months old, have complicated severe acute malnutrition and require hospital and patient care. It has a mortality rate up to 30% in addition to protein and energy. Excuse me. Energy deficiency: there is electrolyte mineral deficiency, potassium, zinc, and magnesium, as well as micronutrients and vitamin deficiency. Vitamin A. Acute malnutrition comprises the WHO 10 essential steps. Stabilization is to treat or prevent hypoglycemia urgently, treat or prevent hypothermia, treat or prevent dehydration, but avoid fluid odor as may lead to heart failure. The standard WHO oral rehydration solution contains too much sodium, 75 millimolar, 2 liter potassium for severe acute malnutrition. This should be given a special rehydration solution, Risomol. Rehydration should be provided orally by nasal tube if necessary. Intravenous are given only for shock. Correct electrolyte imbalance, especially potassium, magnesium, although plasma sodium may be low, they have excess body sodium. Fever infections give broad spectrum antibiotics. Fever and other signs may be absent. Treat oral candida if present. Correct micronutrient deficiency. Vitamin A and other vitamins contained in specialized feeds reduce production of iron is delayed in to second week. Initiate feeding small volumes frequently, including through the night. Too rapid feeding may result in diarrhea. Specialized feeds are widely available. Initially, formula 35, say 5 kilocal per 100 ml, which is low in protein and sodium and high in carbohydrate, is used. Subsequently, formula 100 kilocal per 100 ml, or ready-to-use therapeutic food. The remaining 3 steps are widely during rehabilitation, achieve catch-up growth, provide sensory stimulation, emotional support, provide for follow-up after recovery. This is a figure showing marasmus in 3-month-old baby who was unable to establish breastfeeding because of cleft palate. And this is a baby with kwashiorkor, particularly manifestation of severe protein allergy malnutrition. Some developing countries where infants are weaned late from the breast and the young child diet is high in starch. There's edema around the eyes and feet and legs, hyperkeratosis, depigmentation of the skin, and redness of the here. Standards, it is estimated that in 2015, about 156 million children under 5 were stunted, high for age more than -2 SC, more than -2 Z-score below median. This makes them more susceptible to illness and are more likely to fall behind at schools. As adults, they have an increased risk of becoming obese, developing non-communicable diseases. World Health Assembly endorsed in 2012 a target of a 40% reduction in the number of children who are stunted by 2025, and many multifaceted initiatives are underway. Now, summary, malnutrition worldwide contributes to about a third of all childhood deaths, often a consequence of war and social disruption, as well as famine and natural disaster in developed countries, result from poverty, parental neglect, or poor education, restrictive diets, and children with feeding disorders, chronic illness, allergy, and FOSA. Can we identify anthropometric measurements, marasmus, wasted, wizened appearance, hepatic kwashiorkor, gelacedemia, sparse and depigmented hair, skin rash, angular stomatitis, distended abdomen, large liver, and diarrhea. Vitamin D deficiency is derived from two main sources. Synthesis in the skin, vitamin D3 following exposure to ultraviolet light, or the diet, vitamin D2 or D3. Main function of vitamin D is the regulation of calcium and phosphate metabolism, making it essential for both head, but it also has function in regulation of the immune system if not supplied in adequate amounts in children. Amounts in childhood, rickets and osteomalacia will develop. Vitamin D deficiency usually results from inadequate ultraviolet B exposure, deficient intake or defective metabolism of vitamin D, causing a low serum calcium. This triggers the secretion of parathyroid hormone and normalizes the serum calcium by demineralizes the bone. Parathyroid hormone causes renal losses of phosphate, consequently low serum phosphate levels, further reducing the potential for bone calcification. Vitamin D deficiency usually presents with bony deformity, and the classical picture of rickets can also present without bone abnormalities but with symptoms of hypocalcemia, for example, seizures and neuromuscular irritability causing muscle spasms on the hands and feet, tetany, apnea, stridor, and cardiomyopathy. This position more common for 2 years of age and in adolescents, when a high demand for calcium and rapidly growing bone results in hypocalcemia before rickets develop. Vitamin D metabolism, variation of vitamin D production with time of year and day. When the sun rays enter the atmosphere at an acute angle, the atmosphere blocks the UV part of the rays, so the skin does not convert 7-dehydrocholesterol to vitamin D3. This is the situation during the early and late parts of the day in spring and autumn, and for the entire day in winter if located away from the equator. As a rule of thumb, if your shadow is longer than you are tall, you are unlikely to produce much vitamin D3. This shows sun and blood calcium absorption. Parathyroid hormone, increase bone resorption, increase renal calcium resorption, 125 dihydroxy, vitamin D3 synthesis, and ultraviolet rays to skin, 80 to 90%, 70 hydroxy cholesterol, vitamin D, cholecalciferol goes to liver, vitamin D to ergocalciferol and cholecalciferol from dietary sources 10 to 20%, and then 25 hydroxy vitamin D, calcidiol, then to kidney, and 125 dihydroxyvitamin D, calcitriol, and immunomodulation prevention of autoimmune diseases. And then bone calcification, absorption, blood calcium increase in the intestine, and calcium, just all known as calcium homeostasis. Most countries, sun is the most important source of vitamin D. Vitamin D is not abundant naturally in food except in fish liver oil, fatty fish, and egg yolk. Vitamin D2 ergocalciferol is a form used to fortify foods such as margarine. Vitamin D is hydroxylated in the blood, in the liver, and again in the kidney to produce 125 dihydroxy vitamin D. The most active form of vitamin D is produced following parathyroid hormone secretion response to a low plasma calcium. Rickets. Rickets signifies a failure mineralization of the growing bone or osteoid tissue. Failure of mature bone to mineralize osteomalacia. Cause of rickets are listed in box. These are the causes: nutritional myomu rickets, risk factor, living in northern latitudes, dark skin, decreased exposure to sunlight. For example, some Asian children living in the UK, maternal vitamin D deficiency diets, low in calcium, phosphorus, and vitamin D. For example, exclusive breastfeeding into late infancy or really toddlers or unsupervised dairy free diets, macrobiotics, strict vegan diets, prolonged parental nutrition in infancy, intestinal malabsorption, bowel enteropathy, for example, celiac disease, pancreatic insufficiency, cystic fibrosis, cholestatic liver disease, high phytic acids in diet, for example, chapatis. Defective production of 25 hydroxyvitamin D, chronic liver disease, increased metabolism of 25 hydroxyvitamin D, enzyme induction by anticonvulsants, phenobarbital, defective production of 125, chronic kidney disease, Fanconi syndrome, renal loss of phosphate, and inherited disorders. Etiology cause, the predominant cause of rickets during the early 20th century was nutritional vitamin D deficiency due to inadequate or insufficient exposure to direct sunlight. Nutritional rickets remains the major cause in low and middle income countries. In high income countries, nutritional rickets has become rare or as formula feed in many foods such as breakfast cereals and supplemented with vitamin D. However, nutritional rickets have re-emerged in high income countries in Black or Asian infants totally breastfed in late infancy. It is also seen in extremely preterm infants from dietary deficiency of phosphorus together with low stores of calcium and phosphorus. Children with malabsorption such as cystic fibrosis, celiac disease, and pancreatic insufficiency can develop rickets due to deficient absorption of vitamin D or calcium or both. Drugs, especially anticonvulsants such as phenobarbital and phenytoin, interfere with the metabolism of vitamin D and may also cause rickets. Rickets can also result from impaired metabolic conversion or activation of vitamin D, as in hepatic and renal disease and some rare genetic disorders. Clinical manifestation: the earliest sign of rickets is sensation similar to pressing a ping pong ball, elicited by pressing firmly over the occipital or posterior parietal bones, craniotabes. The costochondral junction may be palpable. Rachitic rosary, wrist, especially in crawling infants, and ankle, especially in walking infants, may be widened, and there may be horizontal depression on the lower chest corresponding to attachments of softened ribs within the diaphragm known as Harrison circus. The legs may become bowed. The clinical feature listed in box. And the case history diagnosis: this is made from dietary history, prolonged breastfeeding, Blood test, serum calcium is lower normal, phosphorus low, plasma alkaline phosphatase, activity high, 25-hydroxy vitamin D may be low, and parathyroid hormone elevated. X-ray of the wrist joint shows cupping and fraying of the metaphysis in the widen epiphyseal plate. Management nutrition is managed by advice about a balanced diet, correction of predisposing risk factors, and by the daily administration of vitamin B, cholecalciferol. If compliance is an issue, a single oral high dose of vitamin D can be given, followed by the daily maintenance. Those foods rich in vitamin D include oily fish and egg yolk in Europe, milk, dairy products, margarine, breakfast cereals, and fruit juices are usually supplemented with vitamin D. Healing occurs in 2 to 4 weeks, can be monitored from the lowering of alkaline phosphatase, increasing vitamin D levels, and healing on X-rays. But complete reversal of bone deformity may take years. This is the Harrison circles, indentation of the softened lower ribcage side of attachment diaphragm, and this is the picture of severe rickets in 3-year-old boy, secondary to celiac disease, has frontal bossing, Harrison sulcus, and bowing of the legs. Clinical features: hypercalcemia rickets, misery, poor growth, short stature, frontal bossing of skull, craniotabes, delayed closure of anterior fontanelle, delayed dentition, ricket rosary, Harrison circles, expansion of metaphysis, especially wrist, bowing of weight-bearing bones, hypertonia, seizures, cardiomyopathy, and heart failure. Now, the summary: rickets nutrition has re-emerged in the UK and Asian and Black infants exclusively breastfed into late infancy. Diagnosis: serum calcium is low or normal, phosphorus low, plasma alkaline phosphate greatly increased, 25-hydroxy vitamin D low, and parathyroid hormone elevated. X-ray features: cupping and fraying of the metaphysis and widen and facilitate other hormone deficiencies in table. Obesity is the most common nutrition disorder affecting children and adolescents in high-income countries and is rapidly becoming a major problem in low and middle-income countries and children of more affluent families. It's important is in its short-term and long-term complications, and that obese children are likely to become obese adults. Definitions in children: the body mass index is weight in kg per height in meter square and is expressed as BMI centile in relation to the age matched and sex matched population. By convention, the UK data from 1990 are used. For clinical use, overweight is a BMI over the 91st centile, and obese is a BMI over the 98th centile. In the UK, the National Child Measurement Program measures height and weight of children in reception class at school, age 4 to 5 years, and in year 6, aged 10 to 11 years, to assess overweight and obesity at primary school. The prevalence of overweight, including obesity, between 1994 and 2013 in England is shown in the picture. It has risen over the last 20 years and is highest among 11 to 15 years old. In the UK, more than a third of children are overweight or obese. Although the trend may have stabilized over the last decade, BMI is not a direct measure of adiposity. It does not distinguish lean from fat mass. This is the case history: seizures and rickets. Muhammad, a 13-month-old Somalian boy, was admitted to the accident emergency department with the generalized febrile seizures. This was initially controlled with the peractin diazepam. Some 20 minutes later, he had another generalized seizure and needed an intravenous anticonvulsant to control his seizures. His mother said that he was a healthy child. He was born at term birth with 3.1 kg and was still breastfed. Some weaning foods were started at 7 to 8 months at age, but he preferred feeding at the breast. He has only recently begun to sit without support. His weight and head circumference were on the 2nd to 9th centile. He had marked frontal bossing, widened wrist, and other epiphyses: Harrison sulci, wide anterior fontanelle, craniotabes, and rosary. He would not take his weight on standing. Investigation showed a low plasma calcium phosphorus concentration, high alkaline phosphatase and parathyroid hormone, and very low vitamin D, confirming rickets. Liver and renal function tests were normal and celiac serology was negative. His risk X-ray showed characteristic features which are shown. Dietary history revealed diet deficient in calcium, vitamin D, confirming nutrition rickets as the cause. Wrist expansion from rickets. X-ray showing wrist showing rickets, end of the radius and ulna expanded, rarefied and cup-shaped, and the bones are poorly mineralized. Now, the complication of obesity, orthopedic slipped upper femoral epiphysis, tibia vera, bow legs, abnormal foot structure and function, idiopathic intracranial hypertension, headaches, blurred optic, disc margins, hypoventilation syndrome, daytime somnolence, sleep apnea, snoring, hypercapnia, heart failure, non-alcoholic fatty liver disease, gallbladder disease and gallstone, polycystic ovarian syndrome, type 2 diabetes mellitus, hypertension, abnormal blood lipids, other medical sequelae, asthma, changes in left ventricular mass, increased risk of certain malignancies, endometrial breast and colon cancer, psychological sequelae, low self-esteem and teasing, and depression. Etiology reasons for the marked increase in prevalence and aren't clear but are due to changes in the environment and behavior relating to diet and activity. Energy dense food are now widely consumed, including high fat fast foods and processed foods. However, there is not no conclusive evidence that obese children are eat more than children of normal weight. The National Food Service showed that UK household energy intake has fallen since the 1970s, and the amount of food purchased has increased by 75%. The intake of full fat milk decreased by 80%. Children's energy expenditure has undoubtedly decreased. Fewer children walk to school, transport in cars has increased, less time at school is spent doing physical activities, and children spend more time in front of small screens, video games, mobile phones, computers, and television rather than playing outside. Children from low socioeconomic homes are more likely to be obese. Females from the lowest socioeconomic quintile are 2.5 times more likely to be overweight when compared with the highest quintile. These are the vitamin deficiency affecting children: vitamin A in butter, eggs, provitamin in spinach, carrots, mango, papaya, and breastfeeding. Children with fat malabsorption, children in developing countries who do not receive supplements. Clinical consequences: increased susceptibility to infection, especially measles. Vitamin A supplementation requiring impaired adaptation to dark light, dry eyes, excessive blinking, blindness due to xerophthalmia. Vitamin D, 90% ultraviolet B exposure, egg yolk, and fish oil added to infant formula and margarine. Children who live further from the equator as UVB low levels are low outside summer months. And children with darker skin, rickets and vitamin E, vegetable oils, children with fat malabsorptions and preterm infants, hemolytic anemia, retinopathy, progressive neuropathy, vitamin K, green vegetables, glass flora added to infant formula given intramuscularly, orally at birth. Newborn infants are relative vitamin K deficiency seen in children with fat metabolism, for example, cystic fibrosis, clotting abnormalities that lead to bruising, bleeding from vitamin K deficiency, hemorrhagic disease of the newborn, water-soluble, thiamine, cereals, pulses, yeast, and these deficiencies include children from South Asian, the polished rice diet, or those with malnutrition. Beriberi. Cardiomyopathies infants, also hoarseness, aphonia, encephalopathy, apathy, drowsiness and seizures, B12, riboflavin, liver, milk, eggs, and vegetables, and deficiency in powder, malnutrition, ankylosing stomatitis, and fissuring of lips. Vitamin C, fresh fruit and vegetables, rare but can occur in children with very restrictive diets and neuro disability. Petechia, poor growth, irritability, painful joints may be mistaken for rickets on X-ray, and folic acid, green vegetable leads, extracts in liver. Children taking antifoliate medications are those with hemolytic conditions and malnutrition, microcytic anemia, neutropenia, and thrombocytopenia. These are the clinical courses. Now, prevention. There are few randomized controlled trials, and most involve complex passages of intervention, include decreased fat intake, fat and increased fruit and vegetables, reduction in time spent in front of small screens, increased physical activity and education. Of these, reduction in time spent on small screen appears to be the most effective single factor. Endogenous cause: overnutrition accelerates leading growth and puberty. Obese children are therefore relatively tall and will usually be above the 15th centile foot. Therefore, if a child is obese and short, an endogenous cause, that is hypothyroidism, Cushing syndrome, should be considered. In children who are obese with learning disabilities or who are dysmorphic, and underlying syndrome must be present. The most common is prader-Willi, obesity, hyperphagia, poor linear growth, dysmorphic facial features, hypotonia, Anderson disease in males. In severely obese children under the age of years, gene defects, leptin deficiency are possible cause. Management: most obese children are managed in primary care, especially pediatric assessment is indicated in any child with complications as shown in the picture, or if an endogenous cause is suspected. In the absence of evidence from randomized controlled trials, pragmatic approach in any individual child based on consensus criteria has to be adopted. Treatment should be considered when the child is above the 98th centile for BMI and the family are willing to make the necessary difficult lifestyle changes. Weight maintenance is a more realistic goal than weight reduction and will result in a demonstrable fall in BMI on their centile chart as height increases. It can only be achieved by sustained changes in lifestyle, healthy eating, regular meals, eating together as a family, choosing nutrient-rich foods that are lower in energy and glycemic index. The glycemic index is ranking of carbohydrate-containing foods based on the overall effect on blood glucose level. Slowly absorbed foods have a low glycemic index rating, and those more rapidly absorbed a higher rating. Increase vegetable and fruit intake, healthy snack food option, decrease portion sizes, drinking water as the main beverage, reduction sugary drink intake, involvements of the entire family in making sustainable dietary changes. Physical activity can be increased by walking and cycling for transport, undertaking household chores and playing. Organized exercise programs have a role, with children and adolescents being encouraged to choose activity that they enjoy and are sustainable. For example, football, dance, and swimming. At least 60 minutes of moderate or greater intensity physical activity is recommended each day. Limiting television and other small screen recreational activity to less than 2 hours per day. Drug treatment and surgery. Drug treatment has a part to play in children over the age of 12 years who have extreme obesity, BMI more than 40 kg per meter square, or BMI over 35 kg per meter square, and complications of obesity. Orlistat is a lipase inhibitor which reduces the absorption of dietary fat and thus produces steatoria. It should not be used for children under 12 years, but may be indicated if there are comorbidities or sleep apnea or severe psychological disturbances. Bariatric surgery is generally not considered appropriate in children or young people unless they have almost achieved maturity, have very severe or extreme vestibular complications, type 2 diabetes or hypertension. All other interventions have failed to achieve or maintain weight loss. American data would suggest laparoscopic adjustable gastric banding is the most appropriate operation. Drug and surgical intervention should only be used in conjunction with a dietary, exercise, and behavioral weight management program and be restricted to specialist centers with multidisciplinary expertise in managing severe obesity. Reducing the prevalence of obesity is a major public health issue. There is recognition in the UK that there needs to be a more joined up approach to obesity with integration between health services, local government, and other key partners based on the needs of local population. Summary: obesity an increased major health issue for children, predisposing them to a wide range of medical, psychological problems in childhood and adulthood, especially type 2 diabetes mellitus and cardiovascular diseases. Defined as a BMI more than 98th centile of the UK 1990 reference chart for Asian sex. Overweight is BMI more than 91st centile. Exogenous cause: hypothyroidism, Cushing syndrome of obesity are rare and more likely to in a child who is also short with falling height velocity. There are also some rare genetic syndromes Successful management requires sustained changes in lifestyle with healthy eating, increased physical activity, reduction in physical inactivity. Drug treatment and surgical interventions only appropriate in a small number of children. Lifestyle changes are difficult to achieve and even harder to maintain. A cultural change form and a misogenic environment is needed. For example, reduction or removal of unhealthy food and drinks and more integrated approach involving health, local government, and other key partners. Now, early childhood caries. What is the most important reason for primary school aged children 5 to 9 years to be admitted in hospital in England? The answer is dental caries with 500 admissions a week. Dental decay can cause pain and discomfort and absence from school. Dental caries is the most common chronic infectious disease of childhood caused by the interaction of bacteria in sugary foods or tooth enamel. The highest caries prevalence is in Africa and Southeast Asia, with a range of from 1 to 2% in infants from high income countries. The term early childhood caries has been adopted to focus attention on the multiple factors that contribute to caries at such early ages rather than ascribing sole causation to inappropriate feeding methods. It is frequently associated with poor diet and poor oral health habits. Streptococcus mutans and Streptococcus cerebrinus are the main karyogenic microorganisms. Infants acquire these organisms from their mothers as mutants can spread from mother to baby during infancy and inoculate even predentate infants. Salivary amylase splits fermented carbohydrates, for example, lactose, fructose, sucrose, galactans, fructans, and polyols into components that can be metabolized by plaque bacteria, leading to acidic end product with subsequent demineralization and increased risk for caries on susceptible teeth. Inappropriate use of a baby bottle has a central role in etiology and severity of ECC. Increasing the time per day that fermented carbohydrates are available is the most significant factor in shifting and remineralization equilibrium towards demineralization. Feeding through the night means there's less protection to teeth because of reduced nocturnal salivary flow. The relationship between diet and dental caries has become weaker, which has been attributed to the widespread use of fluoride. ECC is more commonly found in children who live in poverty or in poor economic conditions, belong to ethnic and racial minorities, are born to single mothers, or whose partners have low education level. Prevention of early dental caries. This includes reduce the bacteria in the mouth of the mother or primary caregiver, chemical suppression using chlorhexidine gluconate in the form of mouth rinses, gels, powder, paste has been shown to reduce oral microorganisms, minimize the transmission of bacteria that cause tooth decay, avoid the sharing of utensils, food and drinks, discourage a child from putting his or her hand in the caregiver's mouth, not licking a pacifier before giving it to a child, or not sharing toothbrushes. Oral health education stimulation of toothbrushing has been among the most successful initiatives. Infants should not be put to sleep with a bottle containing fermentable carbohydrates. Breastfeeding for pleasure should be avoided after the first primary tooth begins to erupt and other dietary carbohydrates are introduced. Children should be encouraged to drink from a cup from their first birthday. Wean from the bottle at 12 to 15 months. Avoid repetitive consumption of any liquid containing fermentable carbs. Avoid between meal snacks and prolonged exposure to food and juice or other beverages containing fermentable carbs. Fluoridated drinking water has been shown to be effective in reducing the severity of dental decay in early population. In England, only 10% population water has a fluoride level optimal for dental health. Water fluoridation schemes are in place in 25 countries. Daily toothbrush from fluoride containing toothpaste is the most cost-effective self-applied method to prevent caries of all ages. This is the end. Thank you very much.